Hi everyone, it's Tammy Sherrill, and in this narrated PowerPoint, I'm going to be talking about respiratory health alterations, specifically in infants and young children. So a little bit of a review. You have had some background on pediatric assessment from block week or loading week. You watched some videos on growth and development and sort of a developmental approach to examination. You've had some readings on anatomic and physiological differences in children, specifically to respiratory, page 778 and 779 in your textbook, and then the infant EXE module and excellent videos on Blackboard site under the infant tab on respiratory anatomy, physiology, assessment, what different types of distress look like, and evaluation and treatment. So the next 4 slides are from that pages of your textbook where we look at those anatomical and physiological differences in children compared to adults. It's really about school age, age 6 or 7, that the pediatric airway matures to be more adult-like. But up until then, there's all kinds of things that contribute to respiratory really being the most prevalent reason for ER visits and hospital readmissions in childhood. I think there's somewhere around 50% of admissions under sort of 5 years of age are due to respiratory issues. So the nasopharynx is smaller and more easily occluded during infection. Sometimes we're dealing with enlarged tonsils and adenoids, and they can cause sort of airway a narrowing or obstruction. Have the small mouth and the large tongue, so that can increase the risk of obstruction. Small nares, and they can become really easily occluded, especially in the case of an infection where there's increased nasal discharge, that type of thing. Got the floppy epiglottis, which makes it very prone to swelling, especially if there's an infection resulting in obstruction. There's increased risk of aspiration based on the position of the larynx and the glottis. And overall, the airway cartilages are immature, so they can become easily compressed or collapse when the neck is flexed. So just like you learn in infant CPR, you only put the infant into the sniffing position. We don't hyperextend the neck. Fewer muscles are functional in the airway, so less able to compensate when there is edema, spasm, trauma, swelling in the airway. And there's large amounts of soft tissue, and the mucous membranes are really loosely anchored, and so once again, increased risk for edema and obstruction. This is just a little diagram looking at sort of differences in pediatric and adult airway. You can see the length is dramatically different. It doesn't really depict the narrowness of the pediatric airway in comparison, but the right main stem bronchus tends to have quite a steep slope in children compared to adults. So for aspiration of like a foreign body or liquid or anything, it tends to go down that right main stem. And just a little depiction of the impact of airway narrowing or swelling that it compares newborn to adult. Certainly it could be really any infant, but you can see on the left what 1 millimeter of swelling does to the airway in the adult versus the newborn or infant. So dramatic narrowing, and with that becomes quite dramatic increase in airway resistance. And then lastly, the nature of the child's chest wall, It's very compliant, and so retractions are quite common in children. You can see the different positioning of retraction: subcostal, substernal, intercostal. I just like to point out suprasternal or supraclavicular. Those are generally uh, show up when there's increased severity, I guess. Suprasternal, sometimes referred to as tracheal tug. If you're seeing that, you know that the infant or child is in more distress than typically like intercostal retractions. So when we look at respiratory assessment, I just wanted to remind you to, refer back to the pediatric triangle, because a lot of things in respiratory assessment come out of that. So we're looking at position of comfort for the infant. Do they prefer to be upright or have the head of the bed elevated? We're looking at their respiratory effort, their work of breathing. So that would be not only the rate, but are they showing increased work, as in grunting, nasal flaring, retractions, all those things that can indicate increased work of breathing. What's their color like? Are they pale? Are they mottled? Is there cyanosis? The nail beds, the lips, the tongue. We know cyanosis is a late sign in children, so if we're seeing that, we know they're in a fair bit of distress. A cough. Cough is another thing important. Is it dry, hacking? Is it productive? Is it weak? Is it forceful? All of those things can provide extra information. Behavior. So that kind of relates to appearance on the pediatric triangle, as far as their level of consciousness. Are they irritable? Are they agitated? Are they restless? What's their cry like? Is it lusty? Is it weak? Are they making eye contact? Are they able to be consoled? Are they interactive with you? Muscle tone, those kinds of things. And then auscultating the lungs. Auscultating a child's chest. I always remember this saying, let sleeping children lie. And you can gain so much out of a respiratory assessment just by observation and, your auditory skills before you move to actually, say, undressing them and auscultating the chest. So try and gather as much of your assessment before you disturb the child, so you can get that, nice resting respiratory rate, heart rate, those kinds of things. Are they on supplemental oxygen therapy, and what type of delivery method and the percentage of oxygen therapy? We use a lot of different oxygen delivery systems in children. We might be using nasal prongs. We might be using a head box, which is like a little plastic fishbowl thing you put over the head and pump some type of humidified oxygen into it. I mentioned vital signs, including O2 sat, really important. And sometimes we'll even do capillary or arterial blood gases if we're really concerned about the child. Other things to assess for would be family or birth history. So family history, is there a history of asthma in the family or cystic fibrosis? And then birth history, are they a premature infant? Because prems often end up getting discharged and going home with ongoing respiratory issues, bronchopulmonary dysplasia, or maybe it's a newborn that had MEC aspiration or transient tachypnea of the newborn. So what's their history? And all of those things will go together to contribute to our respiratory assessment. So signs of respiratory distress, we're looking at initial signs. Typically we'll see some sort of restlessness, difficulty settling, maybe a little bit of irritability, difficult to console, and then tachypnea, tachycardia, and we might see diaphoresis specifically with feeding. Then early decompensation, we're going to see the above signs, but that's going to be then coupled with that increased work of breathing, retractions, grunting, nasal flaring. We might hear some stridor or wheeze. And then late signs, we actually can move to what we call a quiet chest, where there's poor air entry. The cry is no longer lusty. It's a weak cry. There could be apneic periods, gasping, certainly a deterioration in systemic perfusion. So we're going to see modeling cyanosis. And then typically, this is where the heart rate tends to drop off, and we might have bradycardic episodes. So in an adult, they tend to decompensate more slowly over time, whereas children manage to compensate, and then when they do decompensate, it usually happens quickly and they tend to crash really, really fast. Pardon me. So I mentioned to check out the series of videos on Blackboard under the infant tab. What I really like is they provide visuals of, what respiratory distress looks like in infants and children. So it helps you be able to have a concept of that or a visualization of that when you go into clinical. Okay, let's move on to talk about RSV or bronchiolitis. So what is RSV? It is the most common respiratory pathogen in children, the most common cause of bronchiolitis. About 70% of bronchiolitic cases are caused by RSV, and it causes lower respiratory tract disease in infants. About 20 to 25% of hospital admissions in RSV season are bronchiolitis. So quite common. About 1 in 7 infants within the first year of life will have bronchiolitis. Not all severe. Some certainly can be managed at home, but some can get very, very sick and need to be admitted to hospital. So it's highly contagious. For most adults and older children, RSV just causes a mild cold, but in vulnerable infants specifically, they can get quite sick. So if the adult caring for that infant had a cold, or there was a sibling in the house that had a cold, that could be passed on to the child. And it's direct contact with secretions from the hands or by large particles into the eyes, nose. If you were coughing or sneezing over top the infant, they could contact it that way. And it's very resilient. It can survive for 5 to 7 hours on a surface. And so, if I had RSV and I coughed in my hand and touched a doorknob, it could remain active for a long time, or coughed or blew my nose into a Kleenex and left it on a counter. Once again, lives for a long time. So hand washing and, sanitization of surfaces and, wearing a mask if you're sick to prevent passing it on to your infant are all strategies, just like we've learned with COVID. If an infant has RSV, it does increase the risk of asthma and wheezing in later life. So there's a seasonal flux to RSV. It tends to run between December and May. We're probably starting to see some cases of RSV now, getting into mid-November, and then it will peak and typically be gone by late April, early May. Who's most vulnerable? Certainly infants with other comorbidities, and specifically infants with congenital heart defects are really vulnerable. Premature infants, anybody born under 32 weeks, is actually considered high risk. And I would say any prem, but under 32 specifically. And any child that's immunocompromised. So even beyond infants, but even children that maybe they have cancer and they're undergoing chemotherapy or something like that, they can be really at risk for RSV. Okay, so the pathophysiology, it is a lower respiratory tract infection that results in inflammation of the airways. And you can see in the little picture, the airway becomes obstructed from the swelling in the bronchial walls. So that leads to bronchospasm. Airway lining also produces excessive mucus. So there can be a lot of nasal discharge, can be a wet productive cough. So because of the narrowing, there can be air trapping in the lungs and the alveoli that can result in sort of hyperinflation. And ultimately, these kids often end up with high CO2 and low PO2, so hypoxemia is common. It initially starts with mild symptoms, so it comes on like like a common cold. Infant might be irritable, fussy, might be a little more sleepy, runny nose for sure, might have a cough, low-grade fever, and then because of all of that, they may be not eating and feeding as well as typical. And then from there, the next stage is tachypnea, or an increase in respiratory rate becomes noticeable. So severe symptoms, how do we know that things are progressing and we need to take action or get concerned? So based on what you know about respiratory distress in children, just thinking about what signs we will see. And the main one is around increased work of breathing. So we're going to see an even further increase in the respiratory rate and heart rate, grunting, retractions. We might hear crackles or wheezing with diminished breath sounds, cough, nasal flaring, more lethargic, and poor feeding as they progress or refusing to feed at all. So the treatment for RSV is really supportive care. There is, because it's viral, there's no specific antibiotic we can treat it with. So some kids are treated at home if it's mild. If it's more severe, they'd be admitted to hospital and go on isolation. They'd receive humidified oxygen either by nasal prongs or by that head box I described earlier. Hydration is really important. They're losing a lot of extra fluids through insensible water loss with an increased respirate. And so that hydration needs to be either oral fluids if they're able to eat orally, or IV therapy. Some babies with a really increased respiratory rate will need to be switched to nasogastric tube feeds. Typically, if the respirate is over 60, we need to stop oral feeds because of the risk of aspiration and move to nasogastric tube feeds until the work of breathing settles. A lot of times these babies need a lot of nasal suctioning. So typically we would just instill with some normal saline and then gently suction the nares with an appropriate size catheter. Often they're more comfortable with the increase in the head of the bed. It just, pulls those abdominal contents down and allows better diaphragmatic excursion. And then the notion of really careful monitoring. As I said, they can deteriorate really quickly, and so we need to be assessing them quite frequently, especially in the beginning, to assess for that. Some babies, end up having to be admitted to the pediatric ICU and need actual intubation and ventilation for RSV, especially if they have other comorbidities like a history of prematurity or a congenital heart defect. And then the whole focus on decreasing stress for the infant and gentle handling. So the treatment, medications, we would give Tylenol, obviously, to control the fever, keeping the metabolic rate down. And typically now we're using more nebulized 3% hypertonic saline, and we really only reach for nebulized bronchodilators like Ventolin or racemic epinephrine if there's some real significant airway narrowing. But nebulized 3% hypertonic saline in the study the Cochrane collaboration, there was a review in 2013. They found that it was just as effective and actually had a similar, even shortened length of stay in sort of liquefying secretions and reducing swelling in the airway. And then lastly, we do have RSV prophylaxis or vaccination, and it is a series of vaccinations. Usually we start early December, wrap up the last vaccination early May. It is a monthly vaccination, so families need to bring their infant to an RSV clinic in one of the public health departments or at Alberta Children's Hospital. It's a very expensive vaccine, so you have to be deemed at risk. And so, for example, if you're a prem born less than 32 weeks, you qualify for the RSV vaccine. It's, it can run like, I think it's around $5,000 for the 5 or 6 injections that you receive over that time frame, December to May. So for those of you at Alberta Children's Hospital, it's getting into RSV season and you may be seeing some of these babies. And then lastly, watch this little YouTube video. It's an interesting, short little kind of recap on one particular baby's experience getting diagnosed with RSV and admitted to hospital and being quite sick. And so if we think back to last week and our principles of family-centered care, thinking about how you would go about applying those principles given this particular scenario, knowing that we want to keep stress low for the infant and the parent, incorporate the parent in care, make sure they're informed and up to date, and that notion of respect and dignity as well. So I'll leave it at that. And we are going to work through a case study of an infant with RSV in our synchronous learning later today. Thanks very much for watching. Bye.